Start after ceremony.
మళ్ళీ ఆఫ్ చేసి
We'll start this constitution.
వచ్చేసింది. థ్యాంక్ యూ. Good morning, students. Today we are going to discuss about a few common abdominal surgical conditions in children. So, today's content, it's going to be on a discussion on these five topics of surgical conditions commonly seen in children. So there are a number of surgical conditions that occur in children. So it goes beyond the today's capacity to deal with all the surgical conditions. So I'll be dealing with certain surgical conditions that is not quite commonly you see in general surgery or something. So a bit of thing that presents more so in neonatal or in the early infancy. So you will see less number of cases in per se in general surgery. So yeah, the most common topics: tracheoesophageal fistula, congenital diaphragmatic hernia, hypertrophic pyloric stenosis, intersusception, and posterior urethral valve. So I've taken topics that present close to the neonatal age group or in infancy, so that the other topics very commonly like phimosis or any appendicitis, Meckel's diverticulum, which all can present in children. You will be able to see it in adults too. So I'm not going to pick out those topics which are quite common, which you will be reading in surgery per se. So what we are going to deal today in each and every topic is the basic physiology or the understanding of why such a thing happens, what is the problem in each and every condition, and then what are the presentation points, what have we should we look in for in a child or an infant, how they will present it, and then the common investigations and the medical management more so before the child is posted for surgery. So I will not be going into the steps of surgery for any of these things. So tracheoesophageal fistula, it's one of the commonest, congenital anomalies that require surgery early in the, even in the neonatal period or in the early infantile period. And you can see that there are various types of tracheoesophageal fistula. The most common one being atresia with distal fistula. That is, there is the esophagus, the proximal part of the esophagus goes in for an atresia, and the distal part of the one is attached to the trachea. So atresia with distal fistula accounts for 86% of the tracheoesophageal fistula. The next most common one being isolated esophageal atresia. So there is going to be atresia of the esophagus. There is no connection between the trachea and the esophagus. And the rest, next common one is the H-type fistula, isolated tracheoesophageal fistula. Then the other types being atresia with double fistula. That is, there is a proximal part that is atretic and it is not connecting with the distal part of the esophagus, but both these proximal and the distal ends blindly connect to the trachea. And atresia with proximal fistula, what happens is it is the inverse of the first one I said. Like the proximal part connects to the fistula of the esophagus, connects to the trachea, and the distal one is atretic and it is blind pouch. So you can see that it is the most common congenital anomaly, prevalence of around 1.7 per 10,000 live births. Of these, greater than 90% are associated with tracheoesophageal fistula. And exact cause is unknown, but there are certain associations, as in, the associations with maternal age or obesity, low socioeconomic status, European ethnicity, tobacco smoking. Familial cases are rare. There is very low concordance even in twins. Now, before going to the per se, the presentation of how an esophageal atresia or a fistula will present in a neonate, what happens, why where is the problem, why there is a fistula formation or an atresia, what happens is you should understand that whenever the foregut is developing, there is close by the lung buds are also developing. So there is a connection, a layer of connection present, wherein there is a ventricular diverticulum that forms and from where the lung buds actually form. Now what happens is this tracheoesophageal septum has to close properly, and the lung has the trachea and the lung buds has to develop separately. But when that doesn't happen properly and there is misconnection, or this septum doesn't close, there is going to be fistula or atresia with fistula that is happening. So it is a process of maldevelopment. Now, 50% of cases are non-syndromic without any anomalies, and rest associated with anomalies like Vater or Vactal. So, Vactal is a very common syndrome that is associated with esophageal problems, especially esophageal atresia or esophageal fistula, tracheoesophageal fistula. So, Vactal is for vertebral, anorectal, cardiac, tracheoesophageal fistula, renal, and limb anomalies. Cardiac and vertebral anomalies account for 32 and 24% respectively. Certain other syndromes like Charge syndrome, wherein you can find other things like coloboma of the eye, heart defects, atresia of Coyne. I think you would have read it in your ENT, atresia of Coyne, and genitourinary anomalies, retardation of growth and development, and ear anomalies and deafness. All these things are associated. So, Feingold syndrome, Charge syndrome, Vactor or Vactal anomalies. So, all these things can be associated in 50% of the cases, but 50% of the cases do occur isolated. So, how is it going to present? So, the one thing that you have to know is esophageal atresia. If it is present, it presents very early. Very rarely, a child with esophageal fistula or something will present a bit later in infancy. But most of the times they present at birth. There is going to be what happens because esophagus is an atretic. Obviously, there is going to be problems with feeding, and because when you try to feed, it is not going to reach the stomach. Obviously it is going to regurgitate, and if there is a fistula, it is going to enter the trachea also. So frothing and bubbling at mouth and nose, coughing, cyanosis, respiratory distress, feeding exacerbates these symptoms and causes regurgitation and can precipitate aspiration of gastric contents via a distal fistula causes damaging pneumonitis than aspiration of contents from the blind pouch. So what they are saying is aspiration of contents from the distal fistula, which is connecting to the trachea, will cause pneumonitis because it is in continuity with the trachea. So it is better to aspirate from the blind pouch. And the infant with pure TEF, like tracheoesophageal fistula, H-type tracheoesophageal fistula, might present later with chronic respiratory problems, including refractory bronchospasm and refractory pneumonias. So because it is only fistula and there is no atresia of the esophagus, the child will be able to swallow. But the point is, the child, because of minimal amount of feeds or fluids that can escape, especially the breast milk or something that can escape and reach the trachea, the child will have bouts of cough or chronic refractory bronchospasm and recurrent pneumonias because of aspiration. So the child might not immediately present at birth, but it will present, maybe in 2 to 3 weeks of life or in early infancy, and they will present with recurrent pneumonias. So you can understand that it forms one of the differential diagnosis for a recurrent or persistent pneumonias. And diagnosis, obviously, the first one thing what we do when a newborn is being attended at delivery is, once a child is being temperature and cardiac circulation, respiratory things are being seen, we try to pass a nasogastric tube to check the orificial patency. Let it be the choanal patency or the anal patency, we check it. So what happens whenever we pass a NG tube via the choana or an orogastric tube, the tube doesn't pass into the esophagus. So obviously there is an atresia, so it coils back. As you can see in the X-ray, you can see that they have put in a NG tube, but it is coiling back and going above again. Okay, so it doesn't reach the stomach. So, inability to pass a nasogastric tube or a orogastric tube is suggestive of esophageal atresia. So, you have to be careful. You have to take an X-ray and see where is the issue, whether it is getting coiled back. Perinatal suspicion can be there by absence of air bubble in stomach radiologically, and maternal history of polyhydramnias can be seen. Pure esophageal atresia can present with a scaphoid abdomen. Obviously, when the air does not enter, whatever the child is going to take in, the air does not enter the stomach. So the stomach presents basically like a scaphoid abdomen. H-type fistula can be seen by dye injected with with force, or orifice can be seen during bronchoscopy, and confirmed by injecting methylene root during endoscopy when injected in the esophagus. So what happens? You can see here. So here what we have done is, it's a barium swallow. So the child swallows a contrast meal and barium contrast meal, and the X-ray shows a H-type fistula. You can see like the esophagus This is the trachea. You can see the air bronchogram, the tracheal tree. It is also getting highlighted. See, if you are going to take a barium swallow meal, the obviously what you get, you think when you take an x-ray, obviously the esophagus and further on to the stomach, and it goes to the intestines, all these should get highlighted. But what happens here is, here, because of the fistula, because of this connection here, the tracheal tree is also getting prominent. So this is an evidence of fistula. But there are certain disadvantages of doing this procedure. It cannot be done that easily, in especially in infants, and barium per se can even provoke a very severe episode of bronchospasm and hypoxia. But it's just, nowadays we don't use this that commonly, but yeah, it's an experimental procedure that we highlights it. And here, so management, initially, obviously, the first most important thing is maintain a patent airway. So what we have to do is maybe intubate the child if necessary, or whatever it is. We have to maintain an airway, and then the proximal pouch that is being atretic, decompress it and prevent aspirations, so that you don't feed the child anything basically, so that it doesn't go, if there is a fistula ever, it doesn't go to the tracheal component and get aspirated and the pneumonitis occur. So maintain a patent airway, aspirate the pouch from the proximal content, decompress it, and use antibiotics for pneumonia. Then prone position to decrease the aspiration of contents from the distal pouch, and continuous suctioning to decrease secretions from the proximal end. The best one thing obviously is end-to-end anastomosis. So surgical ligation of the tracheoesophageal fistula, followed by end-to-end anastomosis of the esophagus via right thoracoscopic approach, is the definitive treatment. In premature or complicated infants, wherein they have other associated anomalies, or they are not stable cardiovascular wise, or another issues of sepsis or something, fistula ligation can be done. The fistula connecting between the esophagus and trachea, it can be done, and feeding gastrostomy tube is placed. So what we basically do is, if it is possible, we actually go in for a straightaway surgery, or we put that fistula to rest and we put ligate it, so that there is no connection between the esophagus and trachea. And gastrostomy is putting a tube directly into the stomach, and you are feeding the baby via that. And if the gap between the atretic part, that is the proximal and the distal end, is more than 3 to 4 centimeters, a new esophagus, neo-esophagus, is formed by using jejunum or ileum, because the epithelium and other things might closely resemble it, if not completely. We take that thing. And one more thing we have to keep it in mind is, esophagus and other things, they do lengthen with the development of the child. So that is something we have to take care of. So what happens is, whenever they lengthen, so it should be a live segment of the intestine, then only it will also lengthen along with the child's growth. Second one thing, whatever it is we place, because it is going to be from jejunum ileum, the chances of GERD and reflux is going to be high sometimes post the atresia surgery. So complications of surgery, obviously leaks can be there, because we are doing an anastomosis, anastomotic leak, or refistulization, and anastomotic stricture can be there. Most of the children lead a normal life later, but up to 5 years of age, they may experience GERD and reactive airway disease. Those with tracheomalacia gradually improve with time. So the next important abdominal condition, surgical condition that we are going to deal is congenital diaphragmatic hernia. See, I have taken conditions that are more so common in children rather than adolescents or adults, because you don't get to read it much maybe in your general surgery. So at your UG level, these are the quite common conditions that you have to know, surgical conditions that you have to know, that presents at birth or in the neonatal or early infancy. This one, congenital diaphragmatic hernia. So congenital, as in it says, it's at birth, during the formation of the fetus it's going to happen. So it presents at birth. And diaphragmatic hernia, so obviously hernia via the diaphragm. Okay, so it's a communication between the abdominal and thoracic cavities due to congenital defect in the diaphragm, with herniation of abdominal contents into the thoracic cavity. So what happens? Incidence is 1 in 2000 to 1 in 5000 live births. It is equal in both sexes, and most commonly they are on the left side, 85%. Very occasionally they are bilateral, and bilateral diaphragmatic hernias are more or less fatal, and it mostly the fetus dies in utero. You don't even get to babies born with diaphragmatic hernia, especially bilateral. That's quite right, because most of the times it is, if it is that severe, the children are going to die in utero. So associated with syndromes are like Smith-Lemli-Opitz, DiGeorge syndrome. Most of the chromosomal anomalies associated with 13, 15, 18, and 21. Mostly presents in neonates. Very rarely, like 10% may present later or even childhood. In such cases, the outcomes are really good and the mortality is near zero. So, why does a hernia occur? As we saw in tracheoesophageal fistula, whenever there is a problem with the formation of the tracheoesophageal septum, when it does not close properly or there is a persistent connection, the fistula is going to happen. Similarly, there is a problem obviously with the development of the diaphragm. And four distinct components for the development. So you can see here, this is the anterior tendons that is going to arise from the septal transversum. This is the dorsolateral part arising from the peritoneal canals. This is the dorsal part that is going to arise from the esophageal mesentery, and the muscular portions are later on contributed by the thoracic muscles, thoracic muscles. So all these will put together form the diaphragm. So anywhere there is a problem, when these pleuroperitoneal canals do not converge with the septum transversum, anywhere there is an issue, obviously there is going to be a defect in the formation of the diaphragm, and hence there is a chance for the abdominal condition, the contents to go into the via the diaphragm into the thoracic cavity, even when the fetus is being formed during the development of the fetus itself. So you can see here, this is where the Bogdalak hernia, there is a posterolateral defect, the commonest one, and especially left-sided, it is 85%. So Bogdalak hernia is, when you divide the types of congenital diaphragmatic hernia depending upon where is the defect, yes, you have Bogdalak, that is 98%, that is posterolateral defect, and the anteromedial defect being Morgagni's hernia, that is more close. Both of them put together, they are the most common. Among the Bogdalak, left-sided are more common than the right side. So left-sided Bogdalak hernia allows herniation of both small and large bowel and abdominal solid organs like stomach, liver, etc. into the thoracic cavity. Whereas in right side, it is mostly the liver and portion of the large bowel. Bilateral hernias are uncommon and are usually fatal. So how are they going to present? Antenatally, you will have history of polyhydramnias, and ultrasound diagnosis can be done in 50% of the cases. At an average gestational week of around 24 weeks, most commonly from 15 to 24, you will be able to diagnose a diaphragmatic hernia if it is present, and that's why the real mortality rate of newborns are not known, because most of the times when it is detected that early, as in 15 to 16 weeks, earlier than the 20 weeks, most of the doctors advise the MTP, because the chances that the child will survive and morbidity free survival is going to be quite less. So the actual mortality rate secondary to CDH is also questionable, less, because most of the time the mothers do an MTP, they undergo an MTP because the child's survival is questionable. So what happens? Respiratory distress and cyanosis. But what happens basically? Why is there a respiratory distress? What is the problem? Now, when there is a defect and the abdominal, there is the partition between the abdomen and the thorax is not normal, and there is a defect. So what happens? Whatever is inside this side of the abdomen, the stomach, developing stomach, or the intestine, it is going to pouch into the thoracic cavity. What happens whenever there is an output and it comes into the thoracic cavity? It is going to push. There is going to be competition for space for basically the development of the lungs. So for example, in the left-sided hernia, it is going to push the lungs so much, the mediastinum so much, that there is going to be pulmonary hypoplasia. And because of which there is going to be pulmonary hypertension also later on in life. So this is the most important thing. Why there is a problem with congenital diaphragmatic hernia is, it is not only that, it, unlike in other hernias where you suture the defect and maybe you will think that we can push the contents back, suture the defect, why it is going to be a problem. The problem of morbidity, mortality, what occurs in diaphragmatic hernia is basically because the lung is already hypoplastic during development, because it was not it didn't get enough space, it didn't get enough things to grow properly in the fetus environment itself. So even when the child's defect is being closed, the lung has it has the insult has already been delivered. The lung has not grown properly. So whatever it may be, the lung growth cannot be revived back. So such children always have, recurrent pneumonias, they will have cyanosis, they will have, chronic lung disease, and they might go in for primary pulmonary hypertension. All these things are the coexisting morbidities that can occur secondary to this diaphragmatic hernia, and that is why it's a big problem. That is why most of the times when it is detected quite early in pregnancy, as in 15 weeks or 16 weeks, they generally advise MTP to the mother. So that is medical termination of pregnancy. Okay. So respiratory distress and cyanosis at birth is going to be there because the lungs are not developed and they cannot take in air. And what happens is whenever the child tries to take breath, obviously the stomach will also receive some part of air and the stomach starts getting distended. But where is the stomach distending? Once again in the thoracic cavity. So what happens? It further puts pressure on the already small lungs that are there, and so the respiratory distress is going to be worsening. So respiratory distress and cyanosis is at birth, which will worsen the circulatory components also. So they might require resuscitation. Signs: tachypnea, yes, tachycardia, and cyanosis. In respiratory system, chest is indrawing, obviously bulged chest because of all the contents being there, and trachea and apex beak may be shifted. So obviously because everything most commonly left side, that's a mediastinal shift to the right side. So opposite side shifting will be there. The trachea and apex, diminished breath sounds you will not hear, but actually you will hear the vowel sounds in the chest. You will be able to hear the vowel sounds in the chest. And abdomen, it is scaphoid because all the contents of the abdomen are back into the thorax. Now, antenatally, 59% detection at an average age of 24 weeks, and polyhydramnios can be present. Even in intrauterine period, in ultrasound or more so nowadays, MRI is being done, and you can identify the intrathoracic stomach or liver. Thorax, stomach or liver you can find. And fetal MRI, fetal ecography to determine the severity of pulmonary hypoplasia after birth. What do we do? Now, how will the CDH present? The child will present with continuous neonatal respiratory distress at birth, and the child will have frothing, maybe the child will be very cyanotic. The point is, when you are suspecting congenital diaphragmatic hernia, you have already suspected it antenatally or something, or you are sure that you have already diagnosed CDH at birth, never ever do a bag and mask ventilation, because bag and mask ventilation will result in distension of the stomach too, and the distension of the stomach is going to be counterproductive here, because it is going to distend inside the thorax, and it is going to further augment the problems that is already in a hypoplastic lung. So it is going to worsen the respiratory distress. So never ever bag and mask a child or a neonate, especially with a CDH. Neonate, with any person with CDH, obviously any child or any mostly they will present at birth itself. Neonate at CDH. So how they will present? There will be chest X-ray. If you take, you will see coils of intestine fully occupying the chest, and it is pushing the mediastinum to the opposite side. After inserting the NG tube, you will see that the NG tube is not reaching the stomach or below the diaphragm. It is actually higher up in the stomach, because the stomach itself is in the thorax. And arterial progress, yes, it may show metabolic acidosis or respiratory acidosis, and you have to keep a constant watch of the ionic calcium, glucose, and electrolytes. So you can see here, this is an MRI of a fetus that is being taken, and this is the thoracic cavity, and here you can see the black arrow. This is the stomach, and bowel loops are the left red arrows, and you can see liver lower down here. So all the things are actually in the thorax, and here. So this NG tube, it is coiled, it's coiling, and it is inside the thorax. See? These are all intestinal shadows, coils of intestine that is being in the thorax. So as I said, bag and mask is contraindicated. Continuous OG sectioning needs to be done, because your your distension of the stomach comes down. So you prevent distension of the bowels and further lung compression, and avoid hyper, because there is a maldevelopment of a hypoplastic lung. They are already susceptible to easily pneumothorax. So make sure that the peak inspiratory pressure you drive into the child, either via bag and tube ventilation, or when you attach the baby to the ventilator, make sure it is not quite high, because there is a possibility of pneumothorax always. Later, yes, mechanical ventilation. Sometimes surfactant administration might help because there is a hypoplasia and there can be surfactant related surfactant deficiency. The child might require other forms of ventilation, such as assisted ventilation, like high frequency oscillatory ventilator, or extracorporeal membrane oxygenation, and definitely surgery needs to be done. Exit procedures, ex utero intrapartum treatment procedure, wherein certain fetal procedures are tried, and when the child is in as a fetus itself, the defect is tried to be closed so that the development of the lungs are better. So, but not many centers do that here. Follow, yes, GERD, failure to thrive is leading there, progress motility, chronic lung disease, scoliosis and pectus excavatum. Many such things are present as a post CDH repair in a child. The third, so we come to the end of CDH, and the third topic that we will be discussing is hypertrophic pyloric stenosis. Once again, this doesn't present at birth. Okay, the two things that we saw before, tracheoesophageal fistula and CDH, they present as a neonate at birth with on the first day of life. Okay, but hypertrophic pylorostenosis is different. It doesn't present at birth. It more so presents at the end of a month, actually, in a 1 month old infant. And incidence is 1 to 3 per thousand infants, and more commonly males are involved. And they have a history of erythromycin use in the first 2 weeks of life. It might be there. Infants with blood B and O blood groups associations have been found, and they are associated with sometimes with tracheoesophageal fistula, trisomy 18, Smith-Lemli-Opitz syndrome, and eosinophilic gastroenteritis. Now, clinical features. So, what is pyloric stenosis? Pylorus, that is the end of the, just before it connects the duodenum, the stomach end. What happens? That is a stenosis of the pylorus. So, hypertrophic pyloric muscle will be there. So, it stenosis so that the stomach contents cannot pass easily from the stomach to the duodenum. Now, what happens? Because the stomach contents cannot pass easily into the duodenum, there is going to be vomiting. So, non-bilious vomiting, usually projectile following each feed, because every time it is trying to pass, it is not going to be there, so the child vomits it out. And after the vomiting, the babies will be hungry and they will want to feed again. And every time they feed, there will be motility of the gastric peristaltic motility starts, and it tries to push it down the pylorus, but doesn't happen, so the child vomits later on. Now, sign, because there is vomiting and the child is not able to feed, also the child may be dehydrated, and after feeding, there may be a visible gastric peristaltic wave. The peristaltic wave will be so strong, it will try to push the contents into the intestine. But what happens? It is not possible. So it becomes very strong peristaltic wave. On palpation, the enlarged pylorus, described as an olive mass, is palpated, especially after vomiting. See, you can see it here. Here. This is the olive mass. So child is generally they will present around 4 to 6 weeks of age. What are all the investigations? So classically, when the child is brought to you, a male child who is 4 to 6 weeks old, who had been feeding normally and now comes with a history of vomiting, non-bilious vomiting, and you see an olive mass, you see visible gastric peristalsis. What is the next thing? Yeah, you try to take a X-ray, or you take a ultrasonogram. In ultrasonogram, you can actually visualize the pyloric mass, the muscle thickness, the channel length, and the diameter of the pylorus. So all these things should be taken into account. And barium meal X-ray, you will find dilated stomach, because everything in the stomach, it doesn't pass at all down to the duodenum. There is a dilated stomach. Contrast does not pass beyond the pylorus, and because of that, you will have multiple signs. X-ray sites like string side, shoulder side, and double track side. Electrolyte, what happens? Every time the child is going to vomit because the contents are going to be the acidic contents of the stomach that is being vomited out. So HCl is going to be lost. So hypochloremic alkalosis. So chloride is lost and H plus is lost. So alkalosis is there, hypochloremic alkalosis. Along with HCl, there are certain changes with potassium and sodium, and so they finally result in hypokalemia and hyponatremia. Unconjugated hyperbilirubinemia, yes, because the intestines motility and all is restricted because feeds are less, yes, they can present with unconjugated hyperbilirubinemia. Here you can see a dilated stomach, yes. So how much of dilatation? This is the stenotic part and the elongated pyloric channel. This is the string sign. Here you can see here. Hmm? And here it shows a dilated stomach, an elongated pyloric channel, string sign, and bulge of the pyloric muscle into the antrum, that is the shoulder sign. Okay. Management, yes, it is counseling. You have to make the parents understand what is the nature of the defect, and first, before the child is taken up of surgery, you give plenty of fluids to correct the dehydration, then give associated electrolyte abnormalities like hypernatremia, hyperkalemia, what we talked about. So correction of the electrolyte imbalance. Then basically the child becomes very dehydrated and malnourished. So you try to feed in nasodiodinal feedings for patients who are not eligible for surgery, and maybe atropine sulfate can be tried because it's a pyloric muscle relaxant, but the specific surgery is going to be Ramsted's pyloromyotomy. So the next one more thing that is quite common in infants, the next set of age groups, like after 5 months to 6 months, it is the intussusception. I think intussusception would be dealt with even in surgery too, but because it is quite common in this age group, I thought I wouldn't miss it. So intussusception occurs when portion of the intestines or alimentary tract, it gets telescoped into the adjacent segment, and most commonly it is a ileocolic intussusception. So ileum gets telescoped into the colon, and it commonly presents by 5 months to 3 years of age. There is a male female ratio of 3 is to 1. Incidence is 1 to 4 per 1000 live births. You can see here that it is getting telescoped. Here, more so common, you can see it, ileum getting telescoped in the colon. Okay, so intussusceptum is the one that is going in, intussuscipiens is the one that is receiving, which is into which the part of the bowel goes in, telescopes in. And etiology, idiopathic. Most of the time it occurs basically after adenovirus or other upper respiratory tract infection or any bowel infection, eruption, purpura or gastroenteritis. What they say is basically most of the times what happens is, because of the development of the lymphoid organs, the Peyer's patches and other things that occurs in the wall of the mesentery of the intestine. It doesn't occur in the initial 5 months when the child is breastfeeding. More so, they will not be prone for infections because it's exclusive breastfeeding. And later on, when the child is being, given outside feeds, there is a constant exposure to antigens and infection. So the lymphoid organ starts becoming larger in size. So it acts as a leading point because there is a unevenness or something. It acts as a leading point, and that is why Merkel's reticulum, any intestinal polyp, neurofibroma, lymphoma, all these are lead points that will result in intussusception. So when this happens, when ileum telescopes inside the ascending colon, obviously there is obstruction. So the obstruction of the passage of contents is going to be there. So whenever there is obstruction, there is bleeding, and current jelly stones is formed because of the bleeding. Yes, and when the accompanying mesentery, what happens to the accompanying mesentery which has the blood vessels? So ileum has an accompanying mesentery. The blood vessels will be supplying the ileum, so they get ischemia. They get they cannot, the blood supply becomes less, blood vessels become trapped between the layers and the blood flow decreases. So initially edema will be there, then further strangulation of the there, then there will be gangrene or sepsis or shock, and if it is not treated, yes, obviously can result in death. So how will the child present? The child will present with episodes initially, like colicky episodes, sudden pain. The child will start crying, screaming with abdominal pain. It will put the limbs over the knee. Obviously, it is an infant, and the child will not be able to communicate in words. But yes, the child will put suddenly the baby will scream, and after a period of time, the pain comes down, the wave, peristaltic wave comes down, and the child appears calm and relieved in between the attack. there will be vomiting, there can be diarrhea, stools will be, red currant jelly like as you can see in the picture. And if the thing further goes on without treatment, there will be features of shock. We can see in the abdomen, it will be distended, and a tender sausage-shaped mass is felt in the upper mid abdomen, and bowel sound may be absent, and bloody mucus is felt in the digital rectal examination. Investigation. So plain X-ray abdomen may not always show, but what it can show is the obstruction component. Air fluid levels, multiple air fluid levels, or the perforation if it has already occurred. And contrast X-ray, filling defect or coil spring sign can be there. And ultrasonography of whole abdomen, longitudinal view will show a reniform mass, and transverse view will show a downward appearance. Targeted. So you can see here a sausage shaped density. You can see small bowel dilatation, obviously because of obstruction. Then this is the barium minima showing the coiled spring appearance, and there is a filling defect here. So all these are seen in the X-ray. And here this is the hypoechoic edematous outer loop of the bowel, and hyperechoic compressed loop of bowel telescoping within, which is going in. So this is the target side or the donut side, and this is the longitudinal view showing the reniform mass here. Treatment, counseling, put the child on nil by oral. First, correct the dehydration or anything, correct the electrolyte imbalance. You will put in a NG tube and decompress the contents. So, what you will do is basically stabilize the child. So, cardiovascular and things wise, you have to stabilize. You have to stabilize the electrolytes, potassium or hyponatremia, whatever is there, and you will decompress the stomach, and you will give IV fluids. All those things will be done. Then, surgical treatment, there is a possibility for non-operative reduction if it is caught hold of early, not when there is going to be, gangrene, the upset perforation, all those things. No, when there is just a telescoping and you have picked it up early, you can go in for a non-operative reduction with barium or saline or air. It is called hydro or pneumatic reduction. Sometimes it is successful, but the point they say is with pneumatic or hydrosection, there can be recurrence of the intussusception, but people generally go in for non-operative reduction because it is too less traumatizing to the child. So laparotomy with open reduction, yes, resection of the intussusception with end-to-end anastomosis. So we come to the last discussion of abdominal surgical conditions that we will be discussing. So basically, it posterior urethral valve. So I have taken one more condition that is common in presents even earlier in neonates with respect to the kidney. Urinary bladder and urethra. So posterior urethral is the most common obstructive uropathy, and what happens, there are tissue leaflets spanning distally from the posterior urethra to the external urinary sphincter. So it affects in around 1 in 8,000 births. So what happens in posterior urethral valve? Persistence of the urethra. Actually, it is an embryological one, and it has to get, it will have to disappear, but it doesn't happen. It persists. Persistence of the posterior urethral valve is there. So what happens? Narrowing of the bladder outlet. Yes, bladder outlet is narrow. Now, with consequent obstruction of the urinary flow and increased, what happens? There is going to be obviously increased pressure in the proximal organs, dilatation, enlargement. There is going to be VUR, viscoureteric reflex, hydroureter, hydronephrosis, and renal insufficiency. Neonates present with classically palpable distended bladder, very weak urinary stream or urine output is very less or nil output, with or without palpable kidneys, and sepsis going to be there. In older infants and children, they might present with straining during nutrition, poor urinary stream or dribbling of urine, palpable bladder, failure to thrive, UTI, and renal failure. For all the investigation, obviously you will want to do an ultrasound. So ultrasound, what we see, because of the chronic distension with the urine, because the urine cannot pass through the urethra, bladder is thick walled with an elongated and dilated posterior urethra, and hydronephrosis obviously can be picked up on ultrasound. Kidneys may be hyperechoic with loss of normal corticomedullary differentiation. These are all like later, not at birth, but it presents after it is being chronically missed, and it maybe in infancy or something. In MCUG, you will see the elongation of the posterior urethra and urethral stream, that will be distal urethral stream is low, and bladder may show irregular bottom. Antenatally, bilateral hydronephrosis can be present, distended bladder. It can be seen even antenatally. So, whenever there is going to be a bilateral hydronephrosis, a distended bladder, and oligohydramnios, mostly we will suspect posterior urethra valve at birth and keyhole sign. So, you can see here dilated posterior urethra, and here is the keyhole sign. Treatment. Surgical treatment is transurethral ablation of valves can be done, but before that, maybe you have to do a correction of fluid and electrolyte imbalance, any acid base irregularities, and control of infection. Then vesicostomy can be tried, bladder drainage by inserting of feeding tube. All these things can be tried, but the sure shots, treatment for posterior urethral valve is transurethral ablation of valves. So with that, I come to the end of today's class, common surgical abdominal conditions. And any questions or doubts, you can post it. We will answer it, take it later on.